they're doing it in a different room than they used to do.
Mm-hmm.
First time was only 12 years ago, 14, 15 years ago.
Mm-hmm.
take it just once a month, and allows faculty to get
to do this. So I'll tell you right now, it may or may not match what you think is a baseline routine care. And the baseline that this data applies to is that if you were having colon resection, you would basically have an NG placed for the surgery. You might have it early for a few 4 or 5 hours, but it had to come out within 6 hours of the finish of surgery. Majority of them never stayed post bandages. You had to be offered clear liquids the next morning. You had to be dragged out of the bed the next morning. And that was the baseline. We started this with a new experimental drug, and let me show you, this is the placebo group. And what's important to understand is that doing our best of the routine things we thought that we should do day in, day out for every patient, don't leave an NG tube in, get them out of bed, offer them something to eat the next day. We found that with the placebo group, that even at 4 days, only half the people's bowels were starting to work. Half of them were stuck there, for sure. In fact, when you looked at 6 days, almost a week out, 1/4 of the patients still had no activity whatsoever. Now, there was a lot of argument at the time, well, that's normal, that's Mother Nature caring for the injured bowel, the bowel is resting, right? Now, does anybody believe it's really good for your body not to take in calories, just to lay there, non-healing, non-moving? It's interesting that sometimes that is the philosophy. And we reviewed and looked at all the different things that cause the bowel not to be working. And it's multifactorial, and that's the challenge, to understand that there's a lot of reasons why the guts shut down after a major operation, after major trauma. And it ranges from the trauma, its manipulation itself, and there are sham operations where you can open the abdomen of an animal, for example, just wiggle the bowels around, close them back up, and they'll get an ileus from it. Things shut down. There is something to be said with this sort of localized trauma. There are definitely neurogenic and hormonal factors that are released, these stress factors that occur with any type of trauma to the body. There are lots of inflammatory things. The COX system is set off, the prostaglandins, prostanoids dumping wildly. The nausea and vomiting systems are initiated. And there's also all the drugs that we give patients to undergo these surgeries. All the pain medications that they have to have, right? And, of course, there's the whole issue of how much fluid to give. how edematous is the bowel going to get? Does that, in fact, compromise function as well? I can sort of summarize it and simplify it to say there are three main things that affect how fast bowel function returns after major colon surgery. They are the amount of opioids that you give the patient, leading to dysmotility, right? We've known for centuries, if someone has bad diarrhea, how do you treat it? You can give them an opiate. It's been known for a long time. Opium was a great way to stop diarrhea. The inflammatory reaction, the release of mast cells and the localized edema of the bowel, they have almost a neurogenic enteric nervous system within the bowel itself. It's like a miniature CNS in the bowel itself that's involved in the propulsive activity. If you stretch the bowel, it will react and stretch back. All these different things are controlled by localized inflammatory things, as well as a lot of different neurohormonal chemicals that are released locally, topically in the bowel itself, as well as CNS output that helps control your appetite, the desire to eat, and tells you when you need to go to the bathroom. All those things are well known. I'll spend a little more time talking about one particular aspect, especially as an anesthesia practitioner, and realizing that we do know one of the major things we can clinically change is how we manage pain, both through a multifactorial approach, lots of different kinds of drugs, as well as a basic understanding as, well, what drugs have we been using that may have adversely affected how quickly the bowels wake up and recover. And they are especially the opioids. We know that endogenously you have a lot of opioids, right? That's the runner's high and things like that. And all of these different factors are actually released. The endorphins, enkephalins, dynorphins, all of those are endogenous peptides that your body uses to control your appetite, your bowel function, and all these things. It also is involved in reactions to the inflammation and can produce gut paralysis, just like exogenous opioids that we give for pain control can produce complete shutdown of the bowels and guts and all that. These commonly administered pain medications we give are something that we have to really consider. The more I give, the more likely they are to have particular problems. And in fact, Callie published a beautiful paper where he actually looked at almost 100 patients who had a simple, straightforward colon resection. And he plotted, for example, on the x-axis, how many inches long the incision was, and on the y-axis, how many milligrams of morphine the person took in the first 5 days after surgery. And guess what? It was almost a straight line. The bigger the incision, the more morphine they used. And guess what? If you plotted the number of inches long the incision was versus how many days it took for their bowels to come back, same correlation. It's been known for a long time that this was there. And the question is, what do we do about it? It's sad to say that when people do get an ileus, when they don't have their bowels wake up quickly, we get a lot of complications. 25% of the most frequent complications occur after bowel surgery. They are wonderful things like continued problems of pain. As they start to swell up and get the ileus, the pain gets even worse. When they cough, the pain gets worse. The coughing becomes a particular problem because they don't move around. They're miserable. They get worse atelectasis, aspiration issues, deep venous thrombosis and pulmonary emboli go up, the length of hospitalization, discomfort, healthcare costs. There are a lot of problems that we see if we don't manage their return of bowel function perfectly. We see clearly increased utilization, increased nursing time, decreased satisfaction. We can't get the patients out of the hospital. And there is clear data that demonstrates we spend over $1 billion annually in the U.S. dealing with the complications of post-operative ileus and not getting patients out quickly. People are shocked when they ask, well, how many days do most of your colon resection patients stay at Mayo at our place? I can show you beyond a shadow of a doubt, proven with our discharge data, it's typically less than 3 days. Yeah. Question is, how do you get there? And is it possible? And what are the important factors in being able to do this sort of thing? It really involves a multi-group effort. It involves the preoperative preparation of the patient, preoperative preparation of how you get the patient ready, what you anticipate and instruct the patient to expect Because sometimes patient expectations can be a big deterrent. If they expect, I'm going to be there a week, then they will find a reason to stay here a week, right? It happens. You've got to change their expectations. We really had to look at, and I'll go over in detail, all of the intraoperative and postoperative things we've changed. And we'll talk about especially how you maximize the postoperative care. Now, I admit it did help that my wife was the head nurse educator for Mayo Clinic. It did help that she was president of the National Nursing Society. So we got a lot of cooperation. But the bottom line is, if you look at studies where we've specifically implemented these enhanced recovery programs, they typically, just by simplifying, eliminating all the outliers, agreeing on some very simple basic principles, NG tube use, fluid management, pain management, dietary management, as we'll talk about in detail, they always show you'll gain 1 to 3 days, without a doubt. No matter where you probably are today, you can gain a significant, much improved care outcome. And in the end, as I'll show you in our place, we typically, the last measurement we did was the end of 2013. We had actually started saving on that DRG for colon resection $2 million in the last 6 months of 2013. We saved $2 million compared to the previous 6 months for that DRG care. Now, there have been a number of these studies done in the last 4 or 5 years. They basically will try and look at what are we doing now, if we make some changes, what effect does that have, is it really worth making the effort? Here, for example, is a case control study looking at almost 200 patients. They matched some previous controls. What they demonstrate is, as all of these studies have shown you, you will save 1 to 3 days, depending on which study you look at, and you will save $1,000 to $5,000 on every patient as a grouped average. Now, that's not to say that you're ones who get out fast, you've saved all that money. What it really does is eliminate the outliers. It pushes everybody back just enough so that the whole shift of the curve needs to an average savings of $1,000 to $3,000 per patient when you look at them as a grouped average. So I want to make sure that's very clear. It's not every patient will save you $1,000. It's the group average will do that. If you eliminate all those patients who at day 6 or 7, that 25% now becomes only 5%, it's a huge savings, and that's really where it's aimed at. Now, we did send a copy of the slides. Rhonda has that. We also sent a copy of the handout, so it's got copies of all these slides, so you don't have to take copious notes. Apparently the copier broke, so you'll have to get the copies at a later date, but you will get copies of every one of these, as well as the references if you need them. So here's the steps that are involved. It begins with informing the patient, letting them know what the plan is, that they will be going home in 3 to 4 days. You preserve gastrointestinal function by doing a bunch of different things intraoperatively and postoperatively. You minimize this dysfunction that quite often occurs if you're doing what you have been doing. You change how you treat their pain, a lot of preemptive analgesia. We use preemptive analgesia in absolutely every service that we provide as far as surgical stuff. Lots of oral stuff, lots of IV stuff. You're talking 3 or 4 different classes of drugs, typically. We no longer look at that pain management pyramid as a little bit of pain gets a little bit of morphine or fentanyl or Dilaudid. More pain gets a bigger dose, and a lot of pain gets a ton of it. That is not the way we look at it. We have adopted what ASA, American Pain Society, and all these have said. The first thing is nonsteroidals, anti-inflammatories, other agents. If necessary, add low doses of opioids, and only in extremes, if the other things, combinations can't do it, along with locals, epidurals, blocks, and things like that, then they get the stronger, longer-acting opioids. I can tell you for sure, less than half, for example, when I do a cholecystectomy, less than half of them ever even get an opiate for the procedure. It can be changed. And finally, we try and make the patient really part of this, involve them directly. We give pamphlets, we talk about them, encourage them, and you'll see why when you find out exactly all the different steps involved. But let me start with this well-informed patient. We give them very specific criteria of what we're going to do, when we're going to do it. They get these pamphlets. It tells them this is what's going to happen to you on day 1. This is what's going to happen to you on the next day. following day, and by then you may be gone. And then we list the things that could happen and what they might be the challenges, and encourage them to understand this. In fact, when they're admitted, we already schedule their discharge as a planned discharge. We do our best to make sure that we review all the medications they're on, some subtle things that aren't included in the slides, some of their anti-inflammatories. If they've got chronic pain management issues, we'll actually have a consultation with one of our pain docs to help us figure out how do we manage them and get them through this. We do our best to emphasize that they're going to be dragged out of bed the day of surgery in all likelihood. And if not, they're going to spend half the next day out of bed, walking around or sitting in a chair, talking to their friends and family and enjoying being alive, right? We also remind them that they will be eating the next day after surgery, that they will not be starved to death. They will be getting wonderful diet that will help them heal and repair. And then we do our best to explain to them all the different things we do for pain management, but that we will not let them have pain beyond a certain level. It just will not happen. We will give them whatever's necessary. What we do as far as preserving gastrointestinal function is we do believe in the new guidelines and standards that people can take clear liquids up to 2 to 4 hours preoperatively. In these particular patients, we suggest Gatorade, pump it down, yes, stuff like that. There are some great studies demonstrating much faster return of bowel function, better healing, no negative caloric intake drop, positive nitrogen balance, you name it, it's all been studied. We do make a real effort to prevent nausea and vomiting. Lots of different classes of drugs. If we have time at the end, I can explain the different ones that we use in different situations. We do, as I'll show you in a minute, do a lot of this early feeding and also allow them to chew gum, get up all that sort of stuff, absolutely stimulate the bowel activity. Now, this deal about this oral enteral nutrition, please understand this is just basically starting with a clear liquid or a soft diet the morning after surgery. Patients are allowed to have ice chips in the recovery room after bowel resection surgery. They're encouraged to have those. That evening, if they want something else, some juice, whatever, they're allowed to have that. If you look at the actual data in all of these studies, 13 clinical trials, 1,000 plus patients, the data says that you will reduce wound infections, pneumonia rates, and length of stay simply by starting to feed patients early. Give them the opportunity to eat and heal faster. They do not get increased incidence of leaks or dehiscence, and you should not have the philosophy that, well, I can't feed them anything until I hear active bowel sounds. The truth is what can happen, and what does happen is giving them something to eat or chewing gum stimulates the bowels to wake up. In fact, this gum chewing, there have been 13 studies done now in a lot of different settings, bowel surgery, liver surgery, renal surgery, you name it, ENT surgery, all these different things, where they demonstrate simply having patients starting chewing gum that evening of surgery actually will increase return of function, and they typically will say 1 to 1.5 days increase in the speed with which their bowels wake up, and they actively will have bowel movements. The third point, minimizing organ dysfunction. It comes from not doing that routine, aggressive running of the bowel. It comes from no routine mechanical bowel preparations. You don't have to totally empty them the way that many times in the past we've given them 2 days of clear liquids and all these cathartics and things like that. We do have very specific goal-directed fluid therapy designed at giving them a minimum amount of fluid resuscitation. And I'll show you that we have dropped our fluids given intraoperatively from the standard in the past. 5 years ago, it was not uncommon for us to give a liter of albumin, for example. These little old ladies, little old guys, with blood pressure is a little bit soft. Load them up with some albumin. We don't do that anymore. In fact, we're giving probably almost 2,000 cc's less in the operative day, and definitely 2,000 less on the first post-operative day than we used to do. We run them very dry, and it has a very dramatic, in all the studies, effect on return of bowel function. Bowel edema is not a good thing to have happen. I've already mentioned we avoid the nasogastric tubes, and we'll get into this laparoscopy versus like that. As far as the fluid therapy, all of these things demonstrate significantly reduced length of stay if you limit their fluids and actually guide it based upon the patient's real needs, not these routines of let's really fill them up. Their complications are fewer, ICU admission is decreased, return of valve function is significantly shorter time. Now, I can't promise you're going to save more lives because these patients aren't usually dying anyways. So it's one of those subtle things. Should I bother to do it? Well, the quality is the improvement you're going to get. It's not that these patients are dying from these diseases, but the fact is they're suffering and spending a lot more money and time in our hospitals than they need to. There have been a number of 33 studies looking at this use of nasogastric tube following routine abdominal surgery. And I remember when I was an intern, my first 4 years in surgery, absolutely everybody got an NG tube. It stayed in, and every day one of the intern's tasks was to go clamp the tube, listen. Do you hear valve sounds? Okay, well, let's leave it clamped for a day, and we'll come back tomorrow. As I say, now we don't leave those NG tubes in. We put OG tubes in during the procedure for the resection. Now, if they turn out to be septic, if they do 20 different anastomoses, if they come in with bowel distension, ileus, that's a different thing. I'm talking about routine, everyday, elective stuff, the majority of what we do. These studies have clearly shown that they have decreased pulmonary complications, faster return of bowel function, shorter length of stay, no differences in anastomotic leaks. It just isn't a problem. Yes, there is the occasional 5 to 7% of patients who, when you give them the clear liquids the next day, they end up puking their guts out. Then you have to decide, well, do I leave them alone? Do I need to put an NG tube down? That's probably the toughest clinical decision we ever have to make. 9 times out of 10, we say, wait, let's just wait and try it again a little bit later. And that's usually what we do, as opposed to, all right, quick, put an NG tube down. But remember, we also don't give them a ton of opiates, so they're not gorked out of their mind. Their reflexes are intact. They're up out of bed, walking around. So yeah, they can easily handle the fact that they might have thrown up once. Now, what about laparoscopy? I don't know what percentage you do here. We do 97% of all of our intra-abdominal things now are laparoscopic, robotic, stuff like that. It's something to try and achieve. Yes, it's been a nightmare when we first started doing these over a decade ago when we made the big switch. We went from being able to do a total colectomy in under 2 hours to taking 5 hours. And then it became 4, then it became 3. Now it's around 2, back to where we were. But it's taken a lot of practice. Our robotic prostatectomies. Used to do those open under 2 hours, hour and a half. Then we started doing it with the robots. Yes, 6 hours, then 5 hours, then 4 hours. Now we're down to under 3 hours. Even so, you ask, well, is it worth the effort? And I think I'll show you some data where it really is worth it. That you can truly affect length of stay just by switching the technique that you do as well. There's no doubt all these different trials are going to demonstrate bowel function comes back faster, there's less trauma, they require less pain medications, and it makes their management easier. Simply look at the pictures. Can you believe this person has more pain, more discomfort, requires more drugs, and is not willing to jump out of bed the next morning, as opposed to our laparoscopic ones, and we're even doing single port ones now for selected cases. So instead of having 5 or 6 of these little dots, they've got 1. Those are taking 6 hours again, but hopefully they'll get better at it. If you look at these randomized prospective trials or even the retrospective ones, they all demonstrate, whether it's open or laparoscopic, if you do these enhanced recovery things on top of whatever procedure you use surgically, you will gain at least a day in discharge for these patients. Now, the next component, the active pain control. As I mentioned, we do a lot of preemptive analgesia, and I'll show you the list in a minute of the different drugs that we give them. Yes, most of these quite often are oral. So when the patient shows up, first thing the nurse does is come in and say, here's your bucket of pills to take. And yes, it was a big deal, especially for the anesthesia department, to say, well, they've been NPO. Is it safe for me to put them to sleep? Are they going to aspirate? Do the pills dissolve? All that sort of stuff. The studies have shown clearly. I do a lot of outpatient GI, terrible gastrointestinal things. And do we do those sort of things for them? Yes. And when they put the scopes in, if they've had at least a half an hour to dissolve, surprising. Unless they've got particular gastroparesis problems, it dissolves beautifully. Patients under stress have wonderful gastric acid, and it dissolves everything. It absolutely does. Now, other things we do, as I'll mention, I'll go over in just a minute, we do a lot of opioid-sparing techniques. Absolutely very important. Minimize the amount of opioid paralysis you're going to get. We also do a lot of local infiltrations, especially for our laparoscopic things, long-acting pivocaine, ropivacaine, and sometimes even the more expensive lyophilized things today. We also use in selected patients, and we'll talk about this in some more detail, very specific antagonists that completely reverse any opiate effects on the bowels. We've been working on these products for well over a decade. And in fact, 3 of them, I was just at FDA a couple of months ago and got the notice 3 weeks ago that they've also now been approved for chronic opioid-induced constipation in chronic pain patients, not just opioid-induced ileus following bowel surgery. There's also one that is approved for chronic constipation and ileus and just inability to have a bowel movement in patients with terminal illness, taking lots of opioids for pain control. Drugs that you can give them a shot and 75% will have a bowel movement in less than an hour. We published a paper in an intensive care unit of 7 patients who were really very sick. A couple were burns and other things, taking tons of opioids, horrible ileus, unable to feed them whatsoever. Gave them some of these drugs, and miraculously within a day, bowel function comes back. These are something that you're going to think about. But let me talk about more specifically how we do the pain management. The real idea is we used to do a lot of epidurals. Now we do seldom do an epidural. In fact, we don't even bother with epidurals in our laparoscopic procedures. If it's a planned open big bowel resection, yes, we still place a thoracic epidural. We're also doing a fair amount of subarachnoid injections, single shot. Is it necessary? The truth is, Rochester's still doing it pretty frequently because they have extra residents who do nothing but run around doing blocks on patients preoperatively. We don't have those resources, so we've stopped doing that completely. And have I noticed, knock on wood, any big declination in our ability to get patients out or control their pain? The truth is no. So don't believe that you have to do all of these different things. We use a lot of gabapentin as an additional thing, and we'll talk about some of the other drugs here as part of it. We also use ketorolac. Been using it for many years. The surgeon makes the decision, are they bleeding massively at the end of the case? If not, then we give them 15, 30 milligrams IV. And they're prescribed subsequent doses for the next few days as part of the routine care. And I'll show you the order set in just a minute. If you simply use a non-opioid analgesic in supplement to your routine opioid care, as shown here, just by doing that, you decrease how much opioid they take, you actually increase return of bowel function because they take less opioids. It's an important part to look at all these different things that are involved in minimizing opioid effects. And this is an example of one of those drugs that we use certainly routinely for some cases, and then for other ones selected when they have a history of ileus or they have pain management problems and things like that. This drug is called alvimapan. It's basically a very giant, large molecule that binds to opiate receptors. And as we've already mentioned, we know that your GI tract has opiate receptors, your CNS has opiate receptors, and that's where you get the primary analgesia. And the problem with giving patients opioids is the drugs go everywhere. They penetrate the brain, the spinal cord, and peripheral effects, and especially the gut as well. What these particular PAMORAs, as they're called, peripherally acting mu-opioid receptor antagonists, there are 2 currently on the market for routine use, and then 3 more that are being investigated. What they basically do is antagonize the local effects of the opioids in the gut alone because they can't get into the CNS. There's absolutely no effect on analgesia. And certainly I presented all the data from several thousand patients where we've actually looked at the total morphine taken in people given PCAs postoperatively, randomized to these medications, and we can't see any effect whatsoever except a trend to less morphine consumption postoperatively, and I think it's because they're more comfortable. So if they don't get the ileus, they don't get the distension, they actually take even less pain medications. Now, This is an example of the studies that went into the original approval of the first one that's been approved now for almost 4 years. As I said, this one is albumipan. It's not terribly water soluble. It has to be taken as a pill preoperatively. All the studies basically demonstrate that you gain an entire day simply by whatever you're doing today, adding this medication in. It wakes their guts up. What's more important, and what I think is much more of an issue, is yes, it's great to save money, and there's no doubt, if you could see this here, they are clearly discharged. This is the length of stay. You gain at least 1, and in some studies, 2 entire days faster discharge if all you do is add a drug like this that reverses your opiate's effects on the gut. Simple. I like the fact that they have less infections, less cardiovascular morbidity, less GI morbidity, fewer patients got NG tubes placed back in, you name it, across the board. All those things you wanted to list, so there's something more to the quality of this reversal than might be expected. And everyone has to like the fact that, yes, the GI function comes back faster, the length of stay comes back better, and if you look at the total cost, even though you've paid to add this additional drug, you spend less money because more people get out faster, fewer complications, fewer issues and stuff like that. Now, the last component, and then we'll talk about some of the actual details, is promote this patient autonomy. And that encourages them to get up. Well, let's just say they don't have a choice. They will be dragged out of bed. We do specific deep breathing exercises, avoid the pneumonia, all that sort of stuff. Take the catheter out. That's because we've stopped putting epidurals in, so therefore they don't have to have a Foley. They're not tethered to anything. And we really reduce the IV fluids quite often, HEP blocking them on the first postoperative day. So they start to feel thirsty. They're willing to drink those fluids and liquids and eat something because they really are thirsty, as opposed to flooding them with the complete maintenance IV fluid therapy, which we used to do in the past. We make them run a little dry. Now, yes, it's not uncommon for the first time they get out of bed, a little dizzy, little blood pressure dip, lay them back down, maybe give them a fluid bolus the first time just to get them where we want them, ask them to drink some fluids, tell them they'll feel better. Wait an hour, try it again. It might take 2 or 3 times the first morning afterwards, but believe me, the nurses are persistent, very persistent. We do drag them out of bed, and all the studies, as I've already shown you, demonstrate that you'll get a lot less effects as far as DVTs, pneumonia. But in fact, randomized studies where all they did is vary whether or not the person ambulated or not, it's not going to make the bowels work faster. Ambulation does not actually do that. Shimmying them around does not do it. The benefit is in all those other complications. Now, we had a lot of discussion about, well, is it a good idea to try and push people out early? Aren't they just going to bounce back faster? Please look at this and understand what it implies. This is a plot of the day of discharge versus laparoscopic in blue, open resections of bowels in red, or all patients in the green. And what you can see is, as we started discharging patients at day 2, yes, some do go home on day 2, and most go home on day 3, as I'll show you, you say, well, we have a bounce back rate of about 3 to 4% within the first 30 days or so. But in fact, if you can throw them out early because they are behaving well, guess what? They are much less likely to bounce back than the person who continues to have problems, who you can't discharge till day 7 or day 14. And the point is that early discharge definitely does not increase the likelihood of bouncing back. The people who are going to bounce back are the ones you can't ever get out in the first place, who have the complications, who have the comorbidities that develop. They're the ones you have to worry about bouncing back. The people who look good, smell good, and feel good, and they leave on day 3, they stay away. Now, here's our specific data, and I'll zip through it fairly quickly. This is a little over 4,000 patients since 2009 when this sort of became standardized, and we've sort of pushed it out to the different sites. Our preoperative analgesia consists of celecoxib 400 and gabapentin 600. I will give you some ins and outs on that. If they're over age 75, we usually hold the gabapentin. We've had too many of them kind of like strange behaviors and just kind of out to lunch for the entire day. We standardize, looking at our antiemetics. Most of them get dexamethasone. They get Zofran at the end of the procedure. Rochester uses droperidol. We sometimes use Haldol. We also use sometimes some Pepsid, some other little things. But the primary thing is it's mainly dexamethasone and a 5-HT3. Fluids we limit to 500 mils an hour unless they present truly hypovolemic and hypotensive with induction. We just can't keep their pressures up. And post-operatively, it's only 40 mLs per hour, and then we HEP lock it. Usually, this says at 8 hours. Let's be honest, it's usually the first morning after surgery when we get ready to drag them out of bed. It's so much easier to HEP lock it. They're not tethered to anything. So it's easy to get the patients up and about. The patient suddenly realizes, I must be doing well. They're stopping all these things. As I said, we don't do the epidurals. We try and minimize our opioids. Some people will still do the intrathecal injection, single shot, subarachnoid. We don't do any of that at our institution down in Scottsdale or in Jacksonville. And we do the IV ketorolac at the end of the procedure. Post-operatively, they're started on oral oxycodone the next day. If they're really having terrible pain, they get around-the-clock IV and or PO, Tylenol, all right? And they get ketorolac IV for 4 doses, whether they're having pain or not. It's not PRN, it's per clock. We believe in around-the-clock analgesia. Top it off with these extra things if you absolutely have to. You will be surprised how few patients actually need extra on top of that. We offer them the intake within 4 hours. Most of the patients, if they're in the first morning cases, they'll be having dinner that evening. Otherwise, they're definitely tortured to try and drink at least 2 liters of fluids starting the next day because they don't have an IV that's filling them up. Evening of surgery, we drag them out once, walk them around their room. Post-op day 1, they're out of bed for close to 8 hours. They get up a minimum of 4 times, parked in the chair, walked around the area of the ward. Day 2, again, more walks, more time up in a chair, and some of them are gone that evening. As far as the fluids, you can see the differences here. With our new protocol, we've saved at least a liter there. Post-operative in the PACU area, again, because we don't have them running at maintenance fluids. And then the first post-operative day, again, under a liter of IV fluids across the board. If you look at their pain management, when we first started, we did not use the gabapentin, celecoxib, and stuff like that. And the patients in the first 3 to 4 hours definitely were more uncomfortable. If you looked at our newest data from this, which is not plotted here, we basically find that less than 10% now of the patients require any sort of IV opiates whatsoever in the post-operative period. Less than 10%. They can make it through to get that first oxycodone dose the next day if they need it. Now, what messes these things up? What makes them work really well? If you do the subarachnoid injection, it really guarantees you'll be able to keep the total dose of morphine, and they got in the first 2 days to less than 30 milligrams equivalent. That includes the around-the-clock oxycodone if they wanted it and stuff like that. Older patients are easier to have comply, but if you have to convert to an open from a laparoscopic, all bets are off. Chances are you're going to have some challenges, and we do have difficulty in getting them out and compliant. Quite often, the pain management's our biggest issue. That is as well as requiring a lot more fluids than the laparoscopic in our plan. In the original study, there were only 2 surgeons who did the pilot study. They basically discovered that by implementing these new techniques, these new drugs, this new philosophy, that they could get as far as length of stay, being able to discharge patients on day 2. They got to almost half their patients could be discharged by day 2 compared to before they did it, less than 10%. We expanded to the entire group, at least at our institution, of 7 different surgeons, and they went from less than 2% being able to send them home to almost 1/4 by 2011. But there still is a lot of reluctance to push it, and I admit that. Here's the compliance across the thing. We're getting pretty good about it. 85, 90% compliance with nursing, patients, everybody doing what they're supposed to do. If you look at the actual logistic regression for prediction of discharge within that two days, 461 patients, if they stick to the protocols, absolutely, you're going to get them out. If the surgeon does a lot of these, they're more likely to be able to get them out because they really buy into that and they work hard to get the patients out. If you do manage to keep their opiate doses low, they will get out. If they have to be open, they're not going to, and if they're really sick, ASA 3, 4, stuff like that, they're not likely to get out by day 2 or 3. Now, I'll finish with some other important things that I think really should be the convincing point, and that is if you're perfectly compliant, our mean length of stay is now under 3 days. If you're compliant and do a good job, 61% of the patients, this was published back about 2 months ago in BJ, British Journal of Surgery, 61% of our patients went home on post-op day 2. 61%. Now, what are the odds ratio for enhanced recovery protocol elements associated? What's important? These things turn out not to be as important as this fluid management in the end, that you really do need to get them to eat. You need to get them to take the PO enteral fluids and calories. That is as important as the analgesic management and NSAIDs and all those things, but if you mess that up and really flood them with fluids and stuff like that, you're going to have a real challenge to make them be compliant. We basically are saving $1,300 per patient, or a 15% decrease in our DRG costs. Is it worth it? As I said, the last analysis we did was the January to July compared to January to July in 2012, $2 million reduction in cost for that particular care delivered. Back in 2009 when this was started, we were right in the middle of the NSQIP data. And NSQIP has a lot of different factors that are involved, surgical site infections, length of stay, all these different things. Nothing wrong with being in the middle, right? You're good. You're right where everyone else is on the average. By 2010, after we'd enlisted basically all of the entire group, the 7 additional surgeons doing it, we're suddenly in the top 10%. 2011 and guess 2012 in the top 5 in the U.S. by putting those things in place. Those things that led to decreased length of stay, decreased mortality, morbidity, surgical site infections, urinary tract infections, and other infections. All of these things are good, right? These are the CPT codes involved in those, et cetera, and the ASA, functional class, all those things are all compensated. Now, nationally, the current mean length of stay is 14 days for patients who have complications. And we spend $13 billion on caring for patients who have complications of bowel surgery. That's a lot of money. If you can treat them without complications, get them out in a reasonable time period, still over a week, we're spending $11 billion. It's a lot of money. And if you do major resections without complications and you do everything reasonably well with all those different factors, you should be able to get under 5 days, and look at the cost there. Here's the data for Oklahoma. You're pretty much equal with the national averages. 15, you're spending $174 million. You're spending $121 million if you're staying a little bit longer, like 8 days there, and 4.3, $50 million. There's a huge difference. Now, I don't know your specific institutional data. One of the first things you got to do is figure out where you are and what that number is. If you actually survey surgeons who do these procedures, less than 1/3 work in a hospital where they actually have these sort of protocols in place. The majority say, well, we would do it if we had it in place. It's based on science. It's a good idea. It's a challenge to get it done. You got to have standard order sets. You got to have everyone's buy-in. It takes this whole long process, and I don't want to spend time going over it in detail. It's in the handout. But it really does involve getting people a champion. You've got to get a particular person who cares about it. You've got to do all those preoperative things I talked about, the intraoperative, minimal this, the multimodal analgesia, figure out how you're going to manage the fluids. Is a little bit of low-dose infusion of neosynephrine, phenylephrine okay in that particular patient? Minimize your intra-abdominal drains and make sure the patients stay warm. We put a bear hugger on every patient in preoperative holding area. We roast them so that by the time they finish the procedure in the operating room, they've been totally exposed for those 2 hours, they still are normothermic. Those are big little deals. They really are. Early ambulation, minimal lines and drains, opioid sparing, or early oral intake. Now, I finished by saying it's important to have a system that's committed to this. You've got to have localized champions in each of these different departments. And this institutional champion is probably your most important thing. Here, for example, are the standard order sets for Cleveland Clinic that's also participating in this. Again, they actually use gabapentin. They're not into the celecoxib there. They continue the gabapentin postoperatively, which we don't do. Our patient population, as I say, we've had too many little mentation issues. They routinely use the alvimopam, which is given as a pill preoperatively and then used for a couple of days postoperatively to maintain improved bowel function. I didn't show you that we actually have orders for heparin and that sort of stuff, BID, heparin. They use TID, sub-Q, more than we think we need to use. They do offer a PCA for all patients. We do not offer a PCA. We wait and make the patient actually require it rather than have it be part of the routine set of orders. That's just a simpler way, perhaps, to approach it initially. They, again, remove the Foley on the first postoperative day, sit them in the bed, ambulate them times 5 in the hallway every single day, starting on the first postoperative day. They make them chew gum. They give them a stick every 3 times a day, and then they give them clear liquids as tolerated and advance rapidly. And then postoperatively, again, they do the alvimopam, the gabapentin. They do the Toradol for the Q6 for the doses, and then they also use something to stimulate the bowels. And this is an example of what they give their patients to remind them. This is what's going to happen day 3. If you're tolerating this, you may start to eat some solid foods. By day 4, you may be going home, et cetera, et cetera. So I'll finish by showing you again that this whole process has some value. There are very well-documented multiple large series of how to do this. The value really comes in the key take-home messages, which is you've got to get together, get an institutional champion, figure out how to monitor how you are performing and what you're going to monitor to show people and encourage them that it's worth the effort. And I want to finish there so we have time for a couple of questions if anyone has any. Do we have the lights on maybe? No, they have to be eating a regular soft diet at least. So they're forced to have the clear liquids the first morning or the first night. And if that doesn't lead to nausea, vomiting, or the patient discomfort, it's immediately advanced to a soft diet the next meal. And patients, let me tell you, they love it when the dietitian comes in and hands them, would you like to pick out what you want to eat? It's surprising how that encourages them to realize, wow, I'm back eating again. But they've been told that's what's going to happen, and they look forward to it. Yes? The question is, are we checking albumin and other things like that? Are we encouraging special high-protein diets? We have not been routinely. I would tell you that if we had somebody who had, horrible cancer, whatever, that sort of thing, obviously debilitated, yes, absolutely, they are hopefully preoperatively prepared for that. There are some good outcome studies that demonstrate that actually preoperative exercise things and high caloric intake, high protein diets and stuff, if you can get them to eat, are valuable. There's also some stuff that suggests that for like with colon cancer and things like that, that actually affects recurrence rates and metastatic rates. So that good nutrition, I think, is an extremely important part of that. Yes? Yeah, the question he asked about is alvimopam is currently, if you look at the package insert, contraindicated in chronic pain patients. I do know places who will use it if it's just mild opiate chronic use, low-dose OxyContin, things like that. Clearly, it can reverse and precipitate in larger doses. So we, as I said, we don't routinely use it at all in patients who are on chronic opioids. I will say that we have certainly reversed patients with it after 4 to 5 days of obvious worsening ileus. We've usually used methyl naltrexone for that as just single injections rather than the alvimopam. So I think that's probably a little safer. Yes, sir. There's really no advantage to any of those. I think the only point of that particular slide is just to show you that sometimes we are guilty of following suggested maintenance fluid therapy, and that the best approach is individualized patient responsiveness. You do that only by measuring it. And so we've stopped that rule of, well, how much do they weigh? How many quadrants are open? Calculate like that. We do not do that. Instead, if there's issues, then we'll use the esophageal Doppler or other techniques. We don't use central lines, anything like that. Most of these are done with a single large bore IV. That's it. Now, again, remember, this is discussion specific to elective, fairly healthy routine cases. It's not your so-and-so was admitted in septic shock last night with a perforated viscus, and they're doing a total colectomy for that. No, that's completely different. They do get the lines and the A line and all that and stuff. Well, I appreciate the interest. Again, I would say don't think of this as just limited to colon resections. We have similar programs for all of our hips, our knees, all of our GYN cases receive similar fluid management stuff. It's kind of funny now when you look at our OR schedule, almost 2/3 of the cases will say laparoscopic appendectomy and then in parentheses enhanced recovery, which is just to remind everybody you better follow the protocols, stuff like that. And the nurses now know that as soon as a patient shows up, they better go get the bucket of pills for everybody because it just becomes routine. No other questions? Well, good luck with the training, and I hope you maybe will consider some of these ideas. As I mentioned, we did send copies of the slides and the handouts, so all of that's available. And there is this website, POI Education, that's been in operation for almost a decade now. It's got a lot of other useful information in there as well. Thanks.